So last but certainly not least, I'm going to turn it over to our closers, Eastern Virginia. You guys are up.
Hello, can you hear us?
Yep, you're good.
All right, good. All right, my name is Dr. Guju. Mike, this is, I'm a PGY2. This is
Dr. Sanford, PGY3.
Yeah.
Dr. Moran, PGY4.
Dr. Alexander, PGY2.
Okay, awesome. All right, I'll get started with our slideshow. You all see that?
Yep, you're good.
Okay. All right. This is the, all right. Not that good.
Move your screen over that way. Sorry, we're just having some little technical difficulties.
Sorry, we're sharing the screen.
Of course, last minute planning for this. I just want to thank Mike real quickly for going and finding this for us. If you guys have any kind of questions, feel free to jump in. But right now, EVMS, we're a small program, usually about 3 residents per class. We have a good number of faculty here, level 1 trauma center, pretty much in the Virginia Beach kind of metropolitan area, even though kind of addressed as Norfolk. We pretty much have one of the larger population centers in Virginia. Can you guys see the slides now? All right, we'll transition over then.
Okay, fantastic. All right. So we're been a program since 85, kind of the, so like Dr. Sanford was saying, the 3 largest cities in Virginia proper are Virginia Beach, Chesapeake, and Norfolk, making this the largest metropolitan area in the states, which really allows us to receive a excellent diversity of pathology. So I started out on our inpatient rehab service, so I have absolutely seen the whole myriad of neuromuscular disorders, traumatic brain injuries, spinal cord injuries. And on that service, I've actually had to try my hand at a decent number of procedures, in addition to learning basic IPR management. Good balance between inpatient and outpatient. I will be switching next to our outpatient VA service. And I have to tout the pediatrics rotation, as I actually did it last year, as I did my prelim year at CHKD, where we rotate with their PM&R service. All right. Our faculty. These are our full faculty, both core and community. So we are 3 residents per class. So we have 9 residents total to this entire group of faculty. Locations. So Centera Norfolk General is the kind of ivory tower academic institution for the area. The Hampton VA is one of the largest.
It's one of the largest and oldest kind of VAs in the country. It's a huge kind of complex, beautiful waterfront views that you can kind of take a walk on during your spinal cord injury unit if you want to get out and enjoy the weather.
We just have a new opportunity to do another inpatient rehab service at the Centera Virginia Beach General. Children's Hospital of the King's Daughters is the only standalone children's hospital in the state of Virginia, and it just opened up a brand new rehab unit a year ago. And EVMS Andrews Hall, that is our main outpatient clinic. That is where we see all of our sports, spine, and where all the procedures are done. All right. Our rotations. So our schedule is kind of broken up to 10 different rotations. It's a pretty good balance between inpatients and outpatients. I think you see it a little better this next slide. Yes. So you see here how the schedule is kind of broken up between PGY 2, 3, and 4 years. And this, PGY 4 gives you the opportunity to rotate at the new Virginia Beach Rehab Center. All right. So definitely a major perk of coming to EVMS is its location. So I live half a mile from the hospital, which is a super easy commute, which also places me half a mile from the downtown, and it's a 12-minute drive to the beach. So I can easily do all three of those things in a single weekend.
Or day.
Or a day if you're really aggressive. I absolutely love the food here. Fortunately, I don't have a shellfish allergy, so I've really been able to enjoy all of the illustrious seafood we have here. And so we are a beach town, but we do have access to some of the foothills near the Appalachians and some other touristy stuff. Colonial Williamsburg, we're about an hour from that, and then we're an Amtrak away from DC. Okay.
Just transferring over from, there we go.
Yeah. Okay. Now just a brief overview of everything that we've been doing here at EVMS. Now we can open up to questions or anything else. Any other residents want to add anything that I might have glossed over?
So I agree with, so I'm the chief resident this year. Definitely want to agree with Dr. Guju about how we definitely have the myriad of rehab diagnoses. Like he said, we have the level 1 trauma center, so we see plenty of spinal cord injury. We also have the added benefit of seeing them on the acute side on Centeric Norfolk General, but at our VA location, we have a long-term spinal cord injury unit that has about 20-something patients there who live there long-term. So you get the opportunity to both see acute and chronic management of SCI, which is kind of nice. And he also mentioned our pediatric rotation, which is fantastic. We have some great fellowship-trained peds physicians, peds rehab physicians who work with us, and we get to watch them even do like chemo deinnervations with phenol, as well as just Botox and bracing and things like that. And I know I've learned a lot from that rotation. So we have some really great community faculty. And we also have a recent change in program director who has been wonderful and is really excited about finding all sorts of opportunities to continue to grow the program in a whole lot of ways. So we're definitely have lots of opportunity to continue to grow moving forward.
Just want to answer one of the questions quickly about community outreach programs that we have going on here. So once again, we are a kind of large hospital facility. There are a number of outreach programs, a number of kind of support systems. One that we started to get involved with the inpatient rehab side of things is there's a traumatic violence grant ongoing. So we have a kind of a social worker who's with us pretty much every day, kind of getting us involved, see what our spinal cord injury patients need, see what our traumatic TBI patients need, kind of going forward, make sure we're setting those up. And then once again, we can be as participating in those as we want to be. Our program is pretty flexible about what we can, going towards what you engage in and what you want to show interest in, and just taking the lead there. And you're open to do that.
So being the resident on the primary resident on the inpatient rehab service, I've worked with the violence intervention program, and so what we've been doing is it's usually young men ages 20 to 30 who have experienced, from what I've seen, gunshot wounds and other traumatic violent injuries, who once they're discharged get peered together as peer pairs to work through their own injuries and kind of establish a network now that they're discharged from the hospital, and create their own network and give them resources like that. So that has been a really good experience, and one that I did not expect when I first started.
There's also the opportunity for residents to get involved in doing school physicals, for sports physicals. I think we're still getting in line to do them. I know it's been a little bit weird with COVID, but that's something that's been every single year. So it's available for residents who want to get involved, and that's a great way to participate in your community. In addition, you can also go to some of the, I think it's football games. Is that right?
Yeah.
Okay, yeah. So you can also be kind of one of the physicians at football games for the schools in the area. So that's pretty fun.
Is there a formal program? Do you mean for the violence intervention program?
So not for the violence intervention program, I'm guessing you're referring just with the faculty. So you automatically get assigned one of the core faculty members as your mentor. However, large facility, number of people here, you're more than welcome to kind of reach out to other groups and other people who you show interest in. I myself have kind of interest in neuromuscular, so I've reached out to a number of the neurologists there, and they've kind of taken me under my wing, and when I have free time, I can kind of jump in to see a little bit more of what they're doing, and kind of going from there. But you are kind of assigned one kind of core faculty member, and then you kind of can choose the track you wish to take forward. And then
So I can speak to that question a little bit. So as far as anatomy goes, we actually borrowed Dr. Arovich, who is an anatomy professor at the medical school, and he provides us multiple lectures that include both upper and lower extremity, I think back, and neuroanatomy. So he goes through all those with us. Normally, he will try to get us into the cadaver lab to review, especially the limb anatomy. And he likes to do it where he'll guide or have the PGY2 residents primarily guide a lot of the anatomy discussion with supportive feedback from senior residents as far as adding other clinical pearls and things like that. We're trying to figure out a way that we can still do it during COVID. So we might have like still a wet lab where just the PGY2s are there and we kind of do it virtually, but we have definitely some great anatomy options here, which is great. Ultrasound is something that we are working to expand. Our current program director is working on increasing her knowledge on ultrasound herself, and so she's been incorporating that more into her outpatient practice, and is including the residents in doing injections and things in the clinic. She's also very open to any of the residents borrowing her ultrasound machine to practice and review anatomy and things like that. So it's a growing part of our program, but it's something that we're working on.
One of the things we've been doing recently is basically grabbing the ultrasound machine and bringing it to the inpatient rehab group. So there we're looking at strokes with subluxed shoulders. We're tracking nerves with people having kind of bypass surgery and then having kind of weakness. We're also looking at CIDP and basically GBS sort of presentations, kind of tracking those nerves, as well as kind of checking our own anatomy just to kind of cross-check how we're doing, and it's kind of pretty much hands-on. Everyone's there, everyone's accommodating, so we can kind of learn hand in hand.
Oh, and I also just remembered, so on our faculty list, actually a new addition is Dr. Vigueris, who actually did like a sports and spine fellowship and is very skilled in ultrasound. So we're working on starting to integrate him into one of our outpatient rotations to get a little bit more ultrasound exposure that way. So that'll be a valuable resource that we're working to add to our curriculum currently.
Yeah, so like I was saying, Dr. Kwan, the program director, is very trusting to let us take her, $10,000 machine around, but I bring it to the hospital. And so far on my, couple of weeks on IPR, I've got a little over 20 distinct musculoskeletal diagnoses under my belt that, we haven't billed for, but academically it's productive.
So we mentioned Dr. Kwan a fair bit. So she's our new program director. We just, last year, Dr. Curly Navarro's, the Pain Fellowship Director, was also working our academic program. So Dr. Kwan, she's been great. She's very into kind of academics and listening to the residents, trying to get us incorporated in kind of what we want with our residency. She's very open-minded and willing to bring things to the faculty kind of going forward, which has been very good. Dr. Quigley is now going back to the Pain Fellowship program and mentoring those two fellows currently.
Yeah, so pain is a big part of our program. We now have we've expanded the fellowship program to now have 2 pain fellows this past year. So that's been really helpful on the consult service, I think, with all of the pain consults that we get.
So one of our rotations is the inpatient consult service. There you're kind of doing 2 parts. One, you're feeding the IPR, you're seeing the acute diagnosis, the acute traumatic brain injuries on the vent.
You guys have a little under 5 minutes.
Yeah. Just on the vent, as well as working with the acute pain service. Most hospitals are anesthesia kind of pain run. Here we are working with the chronic pain. So we're involved in the PCAs and the really acute management of pain there. And then it's interesting how we can pull out the kind of rehab and the MSK pathology and kind of enlighten our peers about what's going on from that standpoint, and just kind of tie them hand in fist. Yeah. So, So other strengths for the rotation, the pediatric hospital has been a kind of good program to run. Dr. Lesher has been amazing with our residents. I believe one of our previous residents is just completing her pediatric fellowship and joining on to the practice as well.
At
So
Pittsburgh.
She's in her first year. She has one more year to go, but then she's coming back.
So she's coming back here.
Yeah.
And so in time for you guys. And then, so there'll be one more faculty kind of to help guide your way and just through all that. So it's a dedicated hospital, so you get a good pediatric rotation and knowledge base there.
Okay.
Yeah. Any other questions?
Got about 2 minutes left. If anyone has questions, by all means, you can go ahead and unmute yourself or throw them in the chat.
Okay. All right. It's late enough.
Yeah. Thanks for staying up with us.
Yeah, exactly.
Yeah.
Probably all questioned out by now.
Probably.
Just wait till you start interviewing, guys.
Oh, great. Yeah. Do you guys have any questions? Get used to that. Yeah.
Okay.
All
right. Thank you. Thank you for having us.
Good luck to you guys.
Hey, thank you so much.